I'm a gynecologic oncologist, also a trained molecular biologist. I'm glad that you had Shirley as an ovarian cancer patient in the discussion of one of our very first patients. And I will talk to you today about how we have started to incorporate molecular biomarkers to decide treatments in our ovarian and gynecologic cancer patients. So, hold on. Yeah. So, in order to estimate the scope of the problem, I'm showing you here data that estimates the number of new cancer cases and death in females in the United States in 2023. Endometrial or uterine corpus cancer is by far the most common gynecologic malignancy with 66,000 cases in the US in 2023. This incidence is rising at a very concerning rate, which is mostly likely due to more obesity in the United States. As you know, the diet is set up early in life. Our teenagers, young adolescents are getting more obese, and that does increase your risk of developing endometrial cancer. Ovarian cancer, with about 19,700 estimated cases, is actually on a declining slope. We have less cases now, which certainly works in the favor of our patients. Cervical cancer is about 14,000 with a stable incidence. But if you look at the number of deaths that occur from these cancers, ovarian cancer is still the cancer with the highest mortality of about 13,270 cases, but it's very closely followed by endometrial cancer with 13,000. And you don't hear so much about endometrial cancer compared to ovarian cancer as a cancer that likely contributes significantly to mortality in this country. Cervical cancer, we still have, despite the vaccine, a issue in this country with 4,310 patients expected to die in 2023. Let me start with ovarian cancer as a model for molecular biomarker stratified treatment. I'm showing you here in general how we treat this disease. A lot of our patients, unfortunately, present with advanced disease. That's disease that's already spread beyond the ovaries, uterus, or the pelvis, and then involves organs in the upper abdomen, including the omentum, lymph nodes, liver, diaphragm. These patients either get chemotherapy to shrink the tumor, then surgery to remove the remaining tumor. We call this an interval debulking surgery, then more chemotherapy, or they receive the surgical treatment up front, meaning we resect all the tumor and then do 6 cycles of chemotherapy. The chemotherapy is usually a combination of carboplatin and paclitaxel, the most commonly used drugs in gynecologic cancer treatments. Then we're going into the so-called observation or maintenance phase, for which we have some drugs for, which I will talk about. But unfortunately, the majority of advanced ovarian cancer patients, at 70 to 80%, recur with disease at an average of about 2 years, and then need second treatments. We do use chemotherapy, systemic treatments in most cases, sometimes have an option for another surgery. In other treatments, radiation are used less frequently. A patient with recurrent disease, ovarian cancer, is rarely ever curable, and we still need to design treatments that are more effective with longer duration of responses in patients that have become resistant to chemotherapy, in particularly platinum therapy. I show you here how cytoreduction is important in the first treatment of ovarian cancer patients. The goal of any surgery at the beginning of treatment is to remove all disease that we can see and feel inside the abdomen. And if you look at the Kaplan-Meier curve here on the right side, those patients that had a complete cytoreduction have a much better overall survival compared to those patients where the tumor could not be completely resected. We have tried for decades, really, to find biomarkers that could predict an optimal cytoreduction or our ability as a surgeon to remove all the tumor. And despite all the efforts, we really haven't found any predictors that reliably tell us what patients are good candidates for optimal cytoreduction and which patients will not be able to benefit from surgery. We have a lot of drugs with ovarian cancer, though, and this is showing you a landscape of ovarian cancer therapy since 1978. To the left of the dotted vertical line in the middle of the slides are drugs that were approved prior to 2014. Those are chemotherapy treatments as we know them. Cisplatin, carboplatin were some of the first drugs that we had available. Then came the taxanes in the beginning of the 90s, topotecan, liposomal doxorubicin, and gemcitabine. All of these drugs are still part of our standard treatment. But none of these drugs is used based on a certain biomarker. And that changed in 2014 when we had the first drugs approved that actually molecularly driven or stratified by certain biomarkers that we find either in the patient's blood or germline or in the tumor itself. And these drugs, by and large, are PARP inhibitors. Suresh mentioned this. Those are poly-ADP ribose polymerase inhibitors, including olaparib, niraparib, and rucaparib, and drugs that engage the immune system like pembrolizumab, Keytruda, that we know very well. It's particularly efficient in those tumors that are MSI high. The one drug that we don't have biomarkers for is bevacizumab. It's an anti-androgenic drug that binds to VEGF, or vascular endothelial growth factor. We've tried again for a long time to find predictive biomarker for this treatment, but haven't really found anything that reliably predicts whether patients have a benefit to anti-androgenic therapy or not. The last drug approved in November 2022 was actually mirvetuximab, all the way on the right side. That's an antibody-drug conjugate that is effective in platinum-resistant ovarian cancer patients that have high expression of what we call folate receptor alpha. Now, epithelial ovarian cancers are the one subgroup that is most frequently diagnosed. It's from the surface epithelium of the ovary or more the fallopian tube. And there are a number of diseases in this subgroup. I listed them here. Histologically, we distinguish between high-grade, serous, low-grade, serous, mucinous, clear cell, and endometrioid epithelial carcinomas. And what's interesting is that all these different subtypes are characterized by preferred mutations in different pathways. The high-grade serous carcinomas invariantly have p53 tumor suppressor gene mutation. They're also characterized by frequent mutations in BRCA1 and BRCA2 genes, NF1, RB1, and CDK12. In general, have a high degree of defects in homologous recombination. That is in contrast to the molecular pathways altered in other cancers. Low-grade serous carcinomas, for example, are characterized by BRAF, KRAS mutations. Clear cell and endometrioid carcinomas are highly active in PI3 kinase signaling because of gene mutations in PIK3CA, PTEN, and other genes. Although all these cancers are driven by different molecular pathway, we still nowadays treat them pretty much all the same with our most standard carboplatin taxol treatment. We don't really have specific therapies to address the molecular alterations that we know are present in these different histological subtypes. So as I mentioned, homologous recombination repair genes are frequently alterated in high-grade serous ovarian cancers. About 50% have defects in homologous recombination. And most of these defects are due to BRCA1 or BRCA2 mutations. We find germline mutations in BRCA1 and BRCA2 in about 15 to 18% of patients, and somatic mutations in about 7% of patients. Other genes that are involved in homologous recombination, including RAD51C, the Fanconi anemia gene, or CDK12 gene mutations, are likewise mutated but at lesser frequency. Now, we have taken advantage of the defects in homologous recombination in ovarian cancer by developing what, as Rashta mentioned before, so-called PARP inhibitors. PARP is an enzyme that's involved in single-strand DNA break repair. If the DNA can repair its DNA, then the cell will survive. If it cannot repair its DNA because the PARP enzyme is inhibited, it will ultimately accumulate double-stranded DNA breaks that lead to cell death and less cell survival. Now, as mentioned, we have 3 approved PARP inhibitors, olaparib, niraparib, rucaparib in the clinical setting, and we stratify patients based on their molecular signature, either in the tumor or by the germline, to decide what patients are the best candidate for treatment with PARP inhibition. I'll show you here again those different PARP inhibitors. The efficacy between these PARP inhibitors is very similar. They have different bioavailabilities and half-lives and tissue distribution, but in general, in the clinical setting, as I said, provide, I think, equal benefits. So how do we determine what patients will likely respond to PARP inhibition and what patients will not respond to PARP inhibition, given that PARP inhibitors can have very significant side effects? I think this slide demonstrates how we think about response predictors here, and that comes down to the level of genomic instability in ovarian cancer. A BRCA1 mutated tumor, either germline or somatic, will respond very well to PARP inhibition. A patient whose tumor has wild-type BRCA and has a low genomic scarring index will not respond very well to PARP inhibition. And the group in between, which we call the group that is BRCA wild-type, but is deficient otherwise in homologous recombination, will likely respond to PARP inhibition, not quite as well as the BRCA mutations, but definitely better than those patients that are proficient in homologous recombination repair. We have various assays that tell us whether homologous recombination deficiency is present in a tumor. Listed are 2 assays here that are used quite often. One is the MyChoice assay, that is a consolidated score between loss of heterozygosity, LOH, telomeric allelic imbalance, and large-scale state transitions. And that as a score will tell us whether a patient's tumor is Asia deficient or Asia proficient with a score of less than 42. Other assays have used only loss of heterozygosity here in the foundation assay, that likewise has a cutoff that tells us whether patients' tumors have deficiency in homologous recombination. I might say, though, that we still need to optimize these HRD assays for a more accurate response prediction. There's other platforms that have been developed that I'm not going into today, but regardless, I think we still need to do some work on optimizing these type of studies. Now, how does it work in patients? I show you here one of our landmark studies where patients with advanced ovarian cancer underwent surgery, chemotherapy, as we just talked about. All these patients had either germline BRCA mutations or somatic mutations, so tumor mutations. And patients were then randomized into 2 groups. One group received olaparib as a PARP inhibitor. The other group was followed with placebo. This is a Kaplan-Meier curve that shows you a tremendous difference between those patients that received the PARP inhibitors and the patients that obtained placebo. This is a now long follow-up study and is part of our standard treatment. So any patient that has a BRCA mutation gets upfront first-line maintenance treatment with a PARP inhibitor, olaparib or niraparib. This is also true in the long term. I show you here the 7-year data. Patients that took olaparib with a BRCA mutation have a 67% overall survival at 7 years versus 46.5% that are alive in the placebo group. So by all means, a tremendous difference and a definite benefit for our patients. It is different in those patients that are proficient in homologous recombination. Here on the right side is shown a very similar study. Patients underwent first-line treatment with surgery and chemotherapy, were then randomized to a PARP inhibitor versus placebo. And the difference in those patients that don't have HR deficient tumors is rather minor. There's still benefit in those patients that have wild-type BRCA expression, but are deficient otherwise in homologous recombination, with a progression-free survival of 19.6 months versus 8.2 months in the placebo group when they take the PARP inhibitor niraparib. So it is important for us to do a thorough molecular analysis of our ovarian cancer patients for first-line treatment. And here's an algorithm I think that's rather helpful. Any newly diagnosed advanced ovarian cancer patient will undergo germline testing for genes, particularly BRCA1 and BRCA2. It's not only important for the patient, but of course also important for family members. If patients are BRCA mutated, they will be treated with chemotherapy, surgery, followed by a PARP inhibitor. Occasionally, we do add an anti-angiogenic drug like bevacizumab. If they are wild type in their germline, we proceed with somatic or tumor testing. And if you find that patients are either somatic, have somatic mutation in BRCA, or they're deficient in homologous recombination outside of BRCA mutations, we likewise treat them with the PARP inhibitor and first-line maintenance. Those patients that are proficient are often counseled that PARP inhibitors are not providing a significant difference. And I think we still divide it in terms of thinking about benefit in this category. I personally don't treat patients with PARP inhibitors that have HR proficient tumors, but that might be viewed differently by others. So why is it important to do molecular stratification of patients that should be treated with a PARP inhibitor? Well, it always comes down to quality of life and side effects. And one of the most concerning side effects with PARP inhibition, here shown as olaparib and niraparib, is the development of a lethal side effects, a myelodysplastic syndrome or acute myeloid leukemia. In olaparib-treated patients, the percentage of patients that develop this is about 8% versus placebo with 4%. Niraparib, similar. We don't quite understand the mechanism of generating these side effects, but it's an extremely difficult situation for patients and us to treat. I had patients dying on PARP inhibitors that developed the side effects. Patient dying on PARP inhibition, even without ovarian cancer due to side effects. And that by all means is a really great argument for doing a very thorough molecular analysis of our tumor tissue and deciding what patients will truly benefit and what patients should not be treated with a PARP inhibitor. I want to just mention briefly that this new drug, mirvetuximab soravtansine, is now approved for ovarian cancer patients. It has a completely different biomarker that has nothing to do with homologous recombination, but is much more related to the expression of folate receptor alpha. It's a protein that's found on the surface of epithelial ovarian cancer cells. It is probably not driving any of the pathomechanisms, so it doesn't induce cell proliferation necessarily or induces invasion migration, but it's used as a docking molecule for an antibody-drug conjugate. Once mirvetuximab or the ADC binds to the folate receptor alpha, it's internalized via endocytosis and degraded, and the cytotoxic payload is released into the cell. In this case, it disrupts tubulin that results in mitotic arrest and apoptosis. The reason why we're so excited about this, and this is data that's officially presented a few days ago at the American Society of Clinical Oncology, is shown here. Patients with platinum-resistant disease have response rates that are 10 to 16% with standard chemotherapy, as shown again in this MIRASOL trial. Mirvetuximab in patients that have ovarian cancer with high folate receptor alpha expression have a response rate of 42%, which is a tremendous difference. and it has not really been observed in any other drugs that we have tested in ovarian in cancer that is platinum resistant. It also makes a different overall survival. Again, an unusual outcome to the benefit of our patients. Patients on mirvetuximab have a median overall survival of 16.46 months compared to 12.7 months in the chemotherapy arm. And this is now a treatment that we have implemented here at Stanford. We do these assays in our own lab in pathology. We test every patient with ovarian cancer for folate receptor alpha expression to be able to plan treatment potentially with mirvetuximab at some point in time. So I want to switch gears a little bit because I'm giving you little snippets of what molecular diagnostic does for us in our gynecologic cancer. And I want to switch over to endometrial cancer. The TCGA in 2013 provided us with a new molecular, at that time, classification of endometrial cancer that is shown here. Endometrial cancer can be divided in those that have POL-E mutation, polymerase E. It's a enzyme that's important for proofreading the DNA after replication. It's mutated in about 5 to 15% of patients. If patients are POL-E wild type, then they might be deficient in what we call mismatch repair genes. We call them the MMR deficient endometrial cancer. 20 to 30% of all endometrial cancer have this molecular subtype. If they are MMR proficient, we divide them or stratify by p53 mutations. That is either wild type or p53 mutant. This is a category that we call the no specific molecular profile endometrial cancer. It's a common category that is not characterized by either MMR deficiency, POL-E mutation, or p53 mutations. This has, by all means, become one of the most useful molecular classification in our gynecologic cancer over time. And I'm going to show you now how we potentially can use this stratification to make clinical decisions. To demonstrate this, I want to show you here a trial that's called the PORTEC-3 trial. We are, in this trial, we're trying to understand whether the addition of radiation alone or radiation combined with chemotherapy benefits patients with endometrial cancers that are high risk for recurrence. And without going into any details here, patients had surgery. They were then randomized to receive either radiation therapy combined with chemotherapy or radiation therapy alone. And what we found was in that trial that patient that received the combination treatment overall had a better outcome. What we didn't know at the time this was reported now 5 years ago is whether the outcome also was associated with a certain molecular profile. But we do know that now. Here is shown data published a couple of years ago. The POL-E mutated tumors have a much better outcome compared to any other of the molecular subtypes. The p53 mutated tumors have by far the worst subtypes, and it's driving a aggressive behavior of this tumor that we need to be carefully aware of. All these markers are now available in our clinical testing. We have standard pathology here that tests for MMR deficiency, p53 abnormality, and also for POL-E mutation. So we have this available for our clinical decision making. And it's important to know what patients might benefit from what treatment. And I'll show you here an additional outcome of the trial. This is now treatment outcomes stratified by molecular subtypes. And what I want to point out here is that, again, those p53 mutated endometrial cancers have a worse outcome when they're treated with radiation therapy alone compared to those patients that had a combination of chemotherapy and radiation. And although this data is fairly recent, we now base our decision on the treatment after surgery for the endometrial cancer patients that have p53 mutations and a certain clinical stage on this data, and we rather treat patients with chemotherapy and radiation compared to radiation alone if they have tumors that are p53 mutated. Now, the treatment doesn't seem to affect the outcome in patients that have POLE mutation because that's very comparable, as you see in the close proximity between the blue and red curve. Similarly, when patients have MMR deficient tumor, it doesn't seem to matter whether you give radiation alone or radiation and chemotherapy. Keep in mind, we're always glad to know that we can de-escalate treatment in patients that have a similar outcome, regardless of the treatment. So there's more to be learned about this. We have more trials going on that will prospectively look at whether biomarkers can actually drive decision for patients for the greatest benefit of the outcome. Another association that we have found between the molecular subtypes in endometrial cancer and outcome, particularly for immunotherapy, is shown here. Those patients that have POLE mutated tumor or patients that have tumors with MMR deficiency or MSI high have in general a good response to immunotherapy compared to those tumors that are characterized by copy number variations, but not by MSI or POLE status. The underlying hypothesis here is that those patients with ultra-mutated or hypermutated tumor have more neoantigen expression and therefore have a higher chance of stimulating a meaningful anti-tumor response on the immune system side. And that is true. So we have patients in this very first trial here many years ago that were treated with pembrolizumab. This is PD-1 blockade in patients with very solid tumors, including endometrial cancer. All these tumors had mismatch repair deficiency, and single treatment with one single immune checkpoint inhibitor resulted in high response rate, 21% complete responses and 33% partial responses, including in the endometrial cohort. And at that time, this was very exciting data that's now being confirmed. So patients that have deficiency in mismatch repair genes in general have an excellent response to single immune checkpoint inhibition, as shown here with dostarlimab, 48% in the MSI high group. But when patients present with tumors that don't have deficiency in mismatch repair genes, then the response rate drops down to 20%. But we have an answer for these patients nowadays as well, because we are combining pembrolizumab with another drug, it's a tyrosine kinase inhibitor that blocks RET, VEGF receptor, and FGF receptor pathway that all kind of converge in the RAF/MAP kinase and PI3 kinase pathway. And when we combine pembrolizumab and lenvatinib, the tyrosine kinase inhibitor, in patients with MMR proficient tumors, we see response rates that are much higher than with single agent immune checkpoint inhibition, about 37.2% in this trial here. And we can even enhance the response to immunotherapy with this combination in MMR deficient tumors here with 63.6%, but few patients involved in the trial. And what's even more important for a patient is the duration of response. I show you here the overall survival in patients treated with the combination. It's best in those tumors that are deficient in mismatch repair pathways compared to those patients that have proficient mismatch repair tumors. So definitely molecular stratification allows us to choose the right treatment, the right immunotherapy treatment for our patients. I show you here one of my patients. I think it's always impressive to see what that really does in real life. This is a PET scan. Most of these black dots, except for the brain that always takes up the radioactive sugar doing PET scanning, most of these dots are actually disease. And this is a patient that is extremely unusual, wide distribution of metastasis. I started her in October 2019 on a combination of pembrolizumab and lenvatinib. In 2020, just 5 months later, most of these are gone. And in 2020, August, this is almost a year after I started a year on treatment, almost everything is gone. And I can tell you that today, she continues to be in the treatment, It's going to be 4 years in October, and her disease is extremely well controlled. This treatment continues to work now almost 4 years into it. So in the interest of time, I'm going to briefly tell you about this one biomarker we have in cervical cancer. As you know, cervical cancers are driven by the human papilloma virus, which is invariantly associated with this disease. Now, we do know that PD-L1 is highly expressed in squamous cell carcinoma of the cervix. About 85% of all patients with squamous cell carcinoma of the cervix express this. Brooke Howard, to CM Pathology at Stanford, published a study a few years ago in JAMA Oncology that showed the mechanism of overexpression with co-amplification, co-gain, and disomy. We have used this stratification in patients with cervical cancer to decide on who might be a good candidate for this treatment. I show you here how patients respond with single immune checkpoint inhibition, pembrolizumab, that are PD-L1 positive, about 14.6% response rate. But please note that none of the patients that was PD-L1 negative had response to this treatment. So for single agent immune checkpoint inhibition, PD-L1 expression is crucial. Now, we recently have seen data, and that was just updated at the recent ASCO meeting last weekend in Chicago, that addition of pembrolizumab to chemotherapy in patients with PD-L1 positive squamous cell carcinomas or carcinomas of the cervix in general have indeed a clinical benefit. The overall survival is a year longer in pembrolizumab plus chemotherapy compared to chemotherapy alone. And that, by all means, in this very aggressive disease, cervical cancer, is a major step forward in the treatment of these patients. So I want to conclude with this slide here. Keep in mind that we as clinicians need to work on acquiring tissue for all of you that do science. But the workflow is complex. And from acquiring the tissues through biopsies or surgeries to the pathologist that needs to prepare the tissue, assess the quality of the specimen, then send it to reference labs, perform the right tests, and interpretation of the results. It's a very complex process that requires a lot of education and communication. And I think this initiative of Terestius and Peter will greatly help facilitating this process and also the analysis and interpretation of the data. So I want to thank you for your attention today. This is where I do my work here at Stanford in the Stanford Women's Cancer Center. I know I'm not going to have questions right now, but I do appreciate the participation in this meeting. Thank you.